Okay, so I'm just going to do a brief welcome. So we have a number of people online. This is a hybrid event. We have a live webinar running, as well as several people in the room here. And my job is just to welcome you all. So first of all, welcome to our friends from MacCallum Cancer Centre in Melbourne. Thank you for coming to visit us today and share some of your vast experience on Theranostics. And just before I go any further, also, I just want to acknowledge the First Nations people who are the traditional owners of the lands on which we're meeting today, the Camaragal people, and pay my respects to elders past, present and emerging. And yeah, and welcome everybody. This is the 9th webinar in a series we've been running in partnership with the National Imaging Facility on total body PET. And the topic for today is Theranostics, very, very topical area. And it's surprising that we haven't actually touched on it yet. And we've got two excellent speakers today to talk about Theranostics. And I'm going to hand over now to Professor Dale Bailey, who's going to introduce our speakers. So thank you very much, Dale.
Thank you, Steve. I'd also like to welcome the PDMAC team up today, the Total Body PET team, Michael and your colleagues. It's a great pleasure to have you here visiting with us, and we've got a lot of interactions, I think, coming up throughout the day. I have two speakers, Michael Hofman first, and then Kathy Willowson from Royal North Shore. Michael hardly needs an introduction, but just suffice to say that he's put us on the map in many ways in terms of PSMA diagnostics and treatment. He was named the top researcher in nuclear medicine in Australia, 2024-25. He's had a lot of funding for various prostate trials, but also Michael and I first got to know each other, I think, well, he just told me 21 years ago I lectured him on image reconstruction when he was a trainee. But I think through the neuroendocrine tumour work initially with Theranostics and PRRT, and that's now continued by Grace and his colleagues. He's led the way for Australia, and we are very grateful to that. Most notably, I guess, SNMMI Image of the Year in 2018, I believe, showing the benefits of Theranostics, and that's an image which has now gone viral, I would say, around the world. So, Michael, very pleased to have you here, and we look forward to your presentation. Thank you.
Thank you, Dale, and thank you, Steve. It's a pleasure to be here and to bring the PDMAC team up to Royal North Shore. So I'm going to be talking about the role of a total body PET for Theranostics. And a couple of years ago, we applied for this grant from the Australia Cancer Research Foundation to establish a total body PET program at our centre, which was successful. And the scanner is about to be shipped. So you guys are ahead of us in this domain. So we've come up to learn from you. So we are, very excited to learn some experience and see how it can enhance our growing Theranostics program. So this is a graph of Theranostics at PDMAC over the last 20 years or so. And you can see we've been using lutetium-177 actually since 2005. So for 20 years. And we're about to have our decade anniversary of our first lutetium PSMA at PDMAC. And you can see over the last 5 years, it's been growing very quickly. Last year, we did almost over 1,200 therapies with a range of isotopes, lutetium. And right at the top, you'll see that terbium-161 was growing, still doing some radium. And this is a mix largely of PSMA for prostate cancer and dotatate for neuroendocrine tumours. And we think total body PET's really going to enhance this program. 11 years ago, we did the very first PSMA PET in our centre at PDMAC, following on from work that had been done in Germany with small molecules that bind to this receptor labeled to gallium-68. And this is one of the first patients we imaged, and we got these extraordinary images. This patient was thought to have a localised prostate cancer, and in red we can see all the nodal metastases, which even when we went back to look at the CT, they were generally under 5 millimetres. They looked completely normal, and we would say this is a normal CT scan even in retrospect. but extensive nodes. So this patient's management was changed. And I think we learned from our dotatate program for neuroendocrine tumours that producing these sorts of images whilst they change individual patients' management, and they're very clear, it doesn't actually change global practice because the funding authorities, the regulatory bodies, they demand high-level evidence, which are randomised controlled trials. So we did go on to do this very large trial around Australia, 300 patients randomised to PSMA or conventional imaging. And we showed that the PSMA PET had superior accuracy, greater treatment impact, fewer uncertain results, published in The Lancet in 2020 with almost 2,000 citations. But a side benefit of this work was really establishing a network around Australia of nuclear medicine physicians, radiologists, radiation oncologists, urologists, and medical oncologists, and clinical trial staff, all working together. And you'll see that Royal North Shore participated in this first study. It also got our radiopharmaceutical scientists making gallium PSMA around Australia. So very exciting. And you can see how this pro-PSMA trial really resulted in impact, increasing from 2 sites in Australia in 2014 doing this scan to now available on more than 120 PET scanners. And this is really mirrored globally. This is not just a scan, but it's also a treatment. We can change the isotope from gallium-68 for PET scanning to lutetium-177 for therapy. And I think we see in this diagram how total body PET is going to help as imaging is fundamentally linked to the therapy. So we did the first therapy up in our centre almost 10 years to the date, in fact, and we saw some incredible responses in the first few patients that we treated as part of a clinical trial. This is one such patient whose PSA went from almost 1,000 to almost undetectable. This patient was actually, his wife was an oncology nurse, and she was so impressed with the response. She wanted to make other people aware of this, and this newspaper article was published. And she wrote that before the treatment, he was on heavy medications to cope with the bone pain. He was asleep for most of the day, and he felt weak and without hope. And within a week after the first cycle of lutetium PSMA, he was up cleaning the garage without painkillers. And as a former oncology nurse, she'd never seen anything work like this before. We produced this image that Dale alluded to in the introduction, which won an award at the American Nuclear Medicine Society meeting, which is the image of the year. It's an image they choose from around 2,000 abstracts every year that they think highlights the most promising research in nuclear medicine. And then we went on to use that pro-PSMA network of sites that had been established around Australia to run a randomised trial of lutetium PSMA 617 compared to chemotherapy, which Dale and Royal North Shore also participated in. And we showed that the responses were better than chemotherapy and the toxicities were less, leading to another Lancet publication. And since then, there are 5 global randomised trials of PSMA 617, and 3 of them are actually done in Australia, the therapy, the NZP, and the upfront PSMA trial. So we're bringing this treatment from a last line of treatment to an earlier line of treatment and combining it with other treatments. This newspaper article was published titled "The Billion-Dollar Molecule Fighting Prostate Cancer," and I really didn't like the title because I wanted a health-focused article with a patient-focused title rather than a financial title, but this ended up being a reality when Novartis purchased the rights for this molecule, which was owned by a German company and then a US company for $2.1 billion. And now there's over 35 theranostic companies around the world. It's probably more like 50 since this slide was made. And I think it was the second largest area of mergers and acquisitions in oncology in the last 12 months. So this is great for nuclear medicine to have this investment. And what we're doing at Peter Mac is we have a radiopharmaceutical discovery sciences program where we're trying to develop some novel peptides against targets, and we're using this rapid platform where we can take around 1 trillion peptides in a random sequence, put them in a test tube, and very rapidly isolate which one binds with the highest affinity to a target. And then we can optimize this for theranostic imaging by labeling it, typically with a dodecalator, optimizing the properties so that it's got maximal tumor uptake, maximal renal excretion, tested in small animal models, and take it through to first in human imaging, and we have a number of compounds that are coming through this program and are almost ready for in-human imaging. But a lot of the failure happens in this transition from the small animals into the humans. And this is something where I think total body PET is really going to help. This is an article hot off the press in Journal of Nuclear Medicine where they took a new molecule targeting PSMA called DiPyL. And interestingly, they imaged it, you can see in mouse, pig, dog, monkey, and human. And look at how the biodistribution is so different between all these species. So in the mouse, there's very high spleen uptake. In the pig, there's high heart uptake. In the dog, there's super high lung uptake. In the monkey, there's high bone uptake, all very different than the human. So we really need to avoid imaging too much in these animal models, and we need to go very early into humans, in my opinion, because you can waste a lot of time. And this is where total body PET, I think, is really going to assist. So we'll be installing the GE Omni 128, which is the first total body PET from GE Healthcare in a few months at Peter Mac. And I'm not going to go through the advantages of total body PET compared to conventional PET. You can go to the other webinars, lectures, which cover this in more detail. But I'm going to highlight in the rest of the talk how I think this is going to help, particularly with Theranostics. So this is the most recent theranostic we've been evaluating at Peter Mac, which is a radiolabeled peptide targeting CA9, carbonic anhydrase 9, which is overexpressed in clear cell renal cancer in particular. Made the front cover of J&M around this time last year, a first in human study using gallium-68. But the goal of this study, cohort A, was imaging, but the view was to do therapy with lutetium as well. So we wanted to image as late as possible. And with gallium-68, this is really challenging. At 60 minutes, we saw super striking images with SUVs over 100 in tumour and pretty low background uptake, except for stomach and small bowel. So this was encouraging as a theranostic, but with lutetium being a long half-life, we really want to know what's the biodistribution at 12 hours, 24 hours, 48 hours. And we tried on our PET scanner to image as far out as possible. And with a 68-minute half-life of gallium-68, you could see by the time we got out to 180 minutes, the images were becoming increasingly noisy, and we had to increase the scan time on the patient. So these became very, very long scans. It might be, a 40-minute scan for the patient. And beyond that, it really was not possible to image. And this is where I think total body PET is really going to assist. So does total body PET improve spatial resolution? I'm going to tell you, I don't think it does. The crystals on the total body PET are the same size as the crystals on the standard PET scanner. And this is a graph I've made. Apologies to the physicists, it's very basic. But on the bottom is acquisition time and then image quality, which could be spatial resolution. It could be even temporal resolution. And when we do a 2 to 3 minute bed step on a standard PET with fluorine 18 or gallium-68, we're in that green range, which is that high count range. And I think when you image beyond this, you don't actually improve image quality much. You don't actually see any more. However, with total body PET, we really shift this curve to the left. And what you can see the advantage of it is if you're in this
it'll come back, just go to
lower count range, we can really improve our resolution, which is quite a wide range. And when you look at those lower quality gallium images at 180 minutes, this is really where I think total body PET is going to be revolutionary. This is a study from the group that really invented total body PET, the Micro Explorer, and they've done some fluorine images out to 10 hours, and they look almost as good as 1 hour, which is pretty extraordinary, which is imaging out at 5 half-lives. And I put this table together of the various isotopes we might be imaging, their half-life, what imaging out a delayed time point of 5 half-lives would be. And perhaps with total body PET, maybe we can get out to 7 half-lives with ultra delayed images. So we may be able to image something like I-124 out at 30 days, which is quite extraordinary. So this is very good for theranostic applications where we really want to know what does the biodistribution look like 5 days later, a week later, mirroring the therapeutic isotopes that we are using. This is an image, I think it's right from here, came via Andrew Scott as part of his I-FIRST study, a redifferentiation study in thyroid cancer. And on the left, we can see an I-124 PET scan on a standard PET scanner, and on the right, on the total body PET scanner. And the image quality, not only is it better on the total body PET, but it was done in 12 minutes as opposed to 40 minutes for the scan on the left. A 40-minute scan is actually just not that practical in the real world. You can maybe scan 5 patients a day if you're doing 40-minute scans, but 12 minutes is quite extraordinary. Here's some work we've done at Peter Mac using some radiolabeled CAR T cells. This is a CAR T targeting a particular cell surface receptor in multiple myeloma called BCMA. And we've labelled it at 1 day with a 12.5-hour half-life. And we tried to image out to 61 hours, which was possible on a conventional PET scanner, but this was a long scan. The patient had to be in the PET scanner, for well over an hour, which really just is not that practical. And that's about as far out as we can go. And we really wanted to go out further than that. This is particularly also interesting for zirconium-89 imaging, which has a half-life of 78 hours. This is some work using a zirconium-labeled antibody against CD8 for immunotherapy imaging. Images at Peter Mac, but it's manufactured at the Austin by Andrew Scott, and you can see how beautiful the lymph node drainage basin. This is a patient with metastatic melanoma, and we can see that a reactive or inflamed or active lymph nodes are in the drainage basin at baseline and then after treatment with immunotherapy. But again, these images are very time consuming to do. They're just not that practical on a standard PET scanner. So coming back to Theranostics, with lutetium PSMA, around a third of the patients we treat do extraordinarily well. About a third do have good responses, but then they recur within a short period of time, and around a third really have primary resistance. They don't even get through a course of 6 cycles. How can we improve this? I think number one is by improving patient selection for Theranostics. So here's a patient we imaged for the therapy trial who had a PSMA PET and an FDG PET on the right, merging these scans together and changing the color code. So in blue is PSMA positive disease, in red is PSMA negative FDG positive disease. We can see that more than half the disease we can't target. And when we look at this, it's invisible on the CT, invisible on the PSMA PET, but very visible on the FDG PET. But this requires 2 PET scans, which often requires the patient coming to the hospital for 2 visits. And this is an area where I think total body PET can help. And there's three ways it can really help. The first one is you can potentially acquire 1 scan, but use the dynamic component of the scan to separate the 2 PET traces. We inject one and then 15, 20 minutes inject another. And by looking at the clearance kinetics, the signals can be separated. This has been done actually with brain imaging, even on a standard PET scanner, but potentially we can do this on a whole body level. Another method may be just to do 2 static scans. Doesn't need to be dynamic, but we can do an ultra low dose scan to start with, and then an hour later or 2 hours later, give a slightly higher dose, still a low dose of the second PET tracer. This has been done. This is a nice article in the European Journal where they did FDG, and 95 minutes later they injected FAPI with gallium, and then imaged at 34 minutes and got really quite beautiful images. So this is now a one-stop shop. The patient's there only for 2 hours, a short visit to the hospital, and we get 2 scans. It may also be possible to eliminate the second CT scan by doing some deep learning and just transferring across the CT scan from the first PET scan. Theranostics is not magical. It's essentially a radiation delivery device. I explained to patients that it's similar to external beam radiation. It's in a liquid form. We give it as an injection. It travels around the body, binds to the tumours, and we can do nice dosimetry with 3 time point SPECT CT and see exactly how much radiation is to normal tissues and to tumours. And what we've seen in our lutetium PSMA work is that the dose to normal organs is actually quite narrow. So it's quite predictable because it's the same. But our doses to tumours are highly variable from patient to patient, really reflecting the variation in PSMA expression across patients. So really big differences. And then when we looked at response, patients that got less than 10 gray to tumour on average, there was one responder for every 10 non-responders. So not a very effective treatment versus most patients responding if they got over 10 gray. And when we looked at this in the therapy study, patients that using the PET scan rather than dosimetry that had an SUV mean over 10 in tumour had a 12 times likelihood of responding to lutetium versus chemotherapy compared to 2 times better in all the other patients. And so this was a predictive biomarker. Now, so those patients with very high PSMA expression had a 90% chance of having a good response to lutetium PSMA. So this is really a very good biomarker. And work just published a few days ago in Lancet Oncology from Louise Emmett here in Sydney, looking at total tumour volume as a biomarker from the ENZA-P study, also showing that this was a predictive biomarker, that patients with a higher volume of tumour quantitatively did better when you added in the lutetium. But all these measures, total tumour volume, SUV mean, these are static measures from a PET scan taken at around 60 minutes. So the question I ask myself is, can we do better with dynamic imaging on total body PET? So this is a nice slide that Price, who's here, has put together, where this is a bit of a theoretical model where we're looking at every little tumour on this scan and doing a dynamic graph of it. And I think what we might see on a total body PET is that this differs between tumour sites. And this may be a better biomarker than what we can achieve with a static measure at 60 minutes. And this is something, we want to look at on our total body PET, and potentially with 2 traces, a PSMA and an FDG. I think this may be a really powerful biomarker and better than anything we've had to date to predict which patients will respond and which patients won't respond. And the last thing that I'm going to highlight that I think total body PET will do better is post-therapy imaging. We think of post-therapy imaging as something you do on a SPECT scanner, but for some isotopes, you can image it very nicely with PET. And yttrium-90 is a good example of this. Yttrium-90 has about 0.0001% positron emission fraction. Dale, you'll correct me if I've got that percentage wrong. And we can image it. These are images taken on our PET, but the counts are low. So we needed to do 20 minutes just of the liver in order to get that scan. And it is quantitative measurement. But if we want to scan the whole body, 20-minute bed steps times 5 to 6, this is not a very practical thing. The patients can't sit in the scanner for an hour and a half. We're able to do quite nice dosimetry with this if we do multi-time point PET imaging. And we can see that these liver metastases received over 67 gray. We're able to estimate the kidney doses less than 5 gray. And when we see such high doses from a single dose and we give the patient 4 cycles, we can be very confident the patient's going to respond, which is in fact what we saw in this patient. Here's some nice work doing some yttrium-90 phantom work in a total body PET. And what we can see is that you still get noisy images with 0.001% positron emission. But if you image for an hour on the phantom, you get pretty much perfect images. And if you increase the number of iterations, it also brings in a lot of noise. But what we can see is that around 20 minutes, at least for the phantom, is pretty much a sweet spot. You're getting very nice images, which kind of mirrors what we did on our standard PET scanner, a 20-minute bed step through the liver. But this is not practical for a whole body. But now we can do 20-minute scan and get the whole body in, which is going to be revolutionary for patients having yttrium-90 therapy. And it might be possible that there's a few other therapeutic isotopes that we can also image. The other one that we'd like to look at is lead-212, which does not have positron emission, but the decay pathway results in a very small amount of pair production. And some of the medical physicists in Queensland have at least shown that in some phantoms, it's possible to image lead-212. So I'll leave you with a quote from Sir Peter MacCallum that inspires all of us at Peter Mac, that nothing but the best is good enough in the treatment of cancer. And leave you with some key points how, I think total body PET may be transformative for Theranostics. Firstly, by really enabling those phase 0 biodistribution studies as we develop new traces. We want to bring them into humans early. We don't want to take patients off and on standard PET scanners for many hours. We want to potentially do an early scan or a late scan and do some dynamic imaging. It's going to be very good for doing delayed imaging up to 5 to 7 half-lives. It's going to be great for imaging multiple traces in the same patient. I think we're going to improve patient selection by routinely adopting multi-tracer imaging in a single visit. Hopefully, dynamic will be better than a static biomarkers. Much work to be done, remains to be seen, and will be great for post-therapy imaging, no doubt for yttrium, but maybe for other isotopes as well. And with that, I'd like to invite you all to come to Melbourne for Prostic 26, which is a conference we're organising in September next year, not this year, but 2026. So very good reason to come down to Melbourne. And in the meantime, if you happen to be watching this webinar in the next few weeks, we also run a webinar series, and our next one is going to be on September 18, and it's going to be focused on terbium-161. So please join.
Thanks so much, Michael. I think you've alluded to a number of things, but the ability to look at the entire body and the kinetics and that is very tantalising with total body PET. I think that's where I see your group in particular with your research focus around the grant and the new radiopharmaceutical development really having a lot of activity, which would be great to see. So Sophie's just going to reinitiate this sharing to solve some of the technical problems in the room. But while she's doing that, I'm going to introduce Dr. Kathy Willowson, my colleague here, Royal North Shore. We are 2 physicists in this hospital in nuclear medicine, and so we've been very involved in both Theranostics and also the total body PET. So Kathy's going to give us a talk about how we're trying to bring that together. We just celebrated our 2-year anniversary of having total body PET at Royal North Shore. So we've had a fair bit of time to have a look at this. And
maybe I can ask a question that was asked online.
Sure.
So I think, or maybe.
Yes, we'll ask a question. Yeah.
So the question is if there's a clinical research in reducing the potential side effects in the kidneys, for example, by blocking PSMA in healthy tissue.
Yeah, I think it's a great question. So when we have any trace of PSMA, there's normal organs, could be salivary glands, it could be kidneys that we want to try to block. And one way to look at this is whatever your blocking approach is, do a scan, rescan, even with gallium. And again, you may want to image out to 4 hours. I think it would be pretty good to test the hypothesis. So in my mind, an example of this is people are using ice packs to try to reduce salivary uptake. And, very early on, we wondered, does this work? Some people were just doing it all the time, and it's quite uncomfortable for the patients. So we just put an ice pack on one side rather than both sides. And when we scanned the patient with lutetium at 24 hours, the parotid uptake was symmetric. There was no difference. So it made me very confident that this is an ineffective approach. It just does not work. But kidney uptake, I think these are things we want to test early on. And we don't want to be testing this using the therapeutic isotope. We want a diagnostic isotope, and total body PET is super ideal now for doing this. But even imagine doing a dynamic scan where you put the ice pack on, take it off halfway through, and see if it changes.
I'm going to do this really quickly before it freezes again.
Okay, thanks, Kathy.
Thank you, Dale, for the introduction. And yes, I just want to talk briefly about the theranostics thing here at Royal North Shore Hospital, in particular in light of the contribution that having the total body PET-CT system has made. So running a theranostic service is obviously incredibly complex, and it does rely on the use of a lot of different things, different complexities that contribute. So first of all, we need to consider production of the radionuclides themselves, the logistics of getting them to site, handling in the laboratory, labelling, particularly for stability in vivo, what the emissions are going to be, what the uptake clearance rates are like in tissue, accuracy of measurement in the dose calibrator, and of course, optimising our imaging and reconstruction protocols for clinical reporting, but also for some of that's a shame. Some of the more advanced image analysis techniques, things like image-based dosimetry. And obviously, all of these things need to be taken into account when running a safe and effective theranostic service. So certainly imaging does play a very big role in the theranostics process. So I just wanted to highlight the three main areas of imaging that I see. So the first is, of course, diagnostic imaging. As Michael has already touched on, diagnostic imaging or baseline imaging in theranostics really allows us to select the right candidates for treatment. So we know that if we're seeing good targeting and uptake on our diagnostic scan, if we're simply switching that diagnostic radionuclide label to a therapeutic emitter, we should again see that same targeting at the time of therapy. And of course, it's worth noting that some of these patients require more than one radiopharmaceutical to be administered for that correct selection process to take place. The other option we have with diagnostic imaging is not only to select the right candidate for treatment, but also to select the right activity for treatment. And this is the realm of sort of predictive or planning dosimetry, and it's an incredibly important thing to be doing. It's not done routinely at the moment in the clinic. But we are seeing it being used more and more. And I think in the future, it will become routine, certainly for some theranostic studies. And theranostics is really unique because it gives us the opportunity to do this. There are some requirements for this, such as serial or multi-time point imaging, and also that data must be fully quantitative so that we can derive things like time activity curves, dose estimates, and hence prescribe the correct activity to reach those target doses that we desire. The second area for imaging is, of course, post-therapy imaging. So it is obviously really important once we've given treatment to check that our targeting is correct. And typically, a lot of the therapeutic radionuclides that we're using, they are emitting gamma rays or perhaps X-rays as part of that chain of decay. That certainly is the case for a lot of our beta minus and alpha emitters. And so typically it tends to be the gamma camera or the SPECT-CT system that is used for the post-therapy imaging. Again, we can go further than just qualitatively confirming the target. We can also quantitatively do this by using post-therapy imaging to look at absorbed dose estimates through post-treatment dosimetry. And this has really been happening a lot in more recent years. Again, it's been, I think theranostics has been a big driver behind the development of a lot of the hardware and software advances that make this possible in nuclear medicine. Certainly quantitative SPECT-CT is very much now a reality in the clinic. So this really is possible, but of course, as I mentioned earlier, there are some requirements such as typically multi-time point imaging, but there are some ways around that, and certainly full quantification. And of course, the third area for imaging in theranostics is looking at the follow-up imaging or measurement of response. So ideally, we're following an identical protocol to that which has been done at baseline imaging. Measuring response obviously is incredibly important in terms of patient management and deciding, the best path forward for these patients. But also from a more medical physics approach, I suppose, it's also incredibly important to gather this information to start trying to better understand the dose-response relationship in the radiobiology that's taking place. It's still not something that's very well understood in the realm of radionuclide therapy. Once we get a better feel for what target doses should be for certain pathologies, certain mutation status, what our threshold doses are for certain organs at risk, then that gives us a whole lot of more information that we can eventually start feeding back into the treatment planning stage at that diagnostic stage. So that is a work in progress. It certainly is happening. And again, access to good quality and quantitative imaging is an absolute must. So now that we've seen the role of imaging, what is it that we have here on campus at North Shore that has really, I think, helped make our theranostic service such a success? And of course, the first thing to talk about in this seminar is the total body PET system, or the Siemens Quadra system in our case. So as Michael touched on, this is a really fantastic piece of equipment. It does have a long axial field of view, which means there are a lot of advantages here. In this case, it's got 4 times the axial coverage for this particular scanner. It also comes at 3 times the price and twice the maintenance costs of a standard PET-CT system. In our case, we've been incredibly fortunate to be part of this collaboration with NIF and the University of Sydney, which has allowed this really amazing piece of imaging technology to be on campus. You can see at the bottom here an indication of the agreement and the arrangement that we have between the 2 parties, being the clinical component through Royal North Shore Hospital and the research component through the University of Sydney. So we still scan the same number of PET patients that we used to do over a whole day on a standard PET-CT scanner, but now because of the advantages of this scanner, which I will go through in a minute, we're able to condense that scanning of 16 to 20 PET patients all done in the morning, and then after lunch the scanner ticks over into research time and the university research patients come. There is also a recent editorial that's been published which really just highlights the advantages of this shared model approach to both the research component and also the clinical component. So there are a number of radionuclides that we are typically scanning on the system. Obviously, our standard diagnostic agents like fluorine and gallium-68, but also some of these more long-lived agents, which Michael also mentioned. They're incredibly promising and I think really important for Theranostics and what it offers us. Things like copper-64, zirconium-89, NiD-124, and then of course Y90 is another case altogether. So using this system in the clinic, the one word that can best describe it, I think, is flexible. It is an incredibly flexible system and it allows us to manage our clinical workload in so many different ways. First of all, fast imaging. So because of the massive gains in sensitivity of this system, on a standard PET-CT system, it used to take us 20 minutes to do a vertex to mid-thigh FDG study. Now we do that in 5 minutes. And as you can see from this early data, we could quite comfortably drop that down to a 3-minute scan if required as well. For our Theranostics patients, this is really fantastic. These patients are typically having multiple imaging appointments, often over many years. And so any chance we get to give them a bit of time saving on the scanner is very much appreciated for them. And also it works for us trying to fit the studies in throughout the day. It's also offering a lot of opportunities for lowering the dose. So we now inject only 60% of what we previously used to inject for a standard whole body FDG PET-CT study. Certainly this trade-off between injected activity and acquisition time allows us to have a lot of flexibility in that approach as well. Having a lower radiation dose through lower injected activity has massive benefits for certain cohorts. Obviously our pediatrics or pregnant patients, and we are seeing more and more referrals for those come through. But again, for our Theranostics patients, which are coming back for so many studies, I know they're having therapy, but still is our responsibility to lower the radiation dose wherever possible over that pathway, which, as I said, often extends over many years. So having this option is really fantastic. Something else that Michael did mention is the beauty of having an extended field of view, which does open up the door for whole body parametric analysis. So because the heart is in the field of view of the scan the entire time, it means that we have access to the contents in the left ventricle and deriving a time activity curve, which allows us to, of course, derive a blood input function to do things like a Patlack-Rutland analysis. So typically we'd be taking just a single image, which is a snapshot in time, usually about 60 minutes post-injection to derive things like an SUV. But the use of this sort of parametric analysis through dynamic PET imaging allows so many different types of things to be done. Not only can we generate things like a KI and a volume distribution map, which give us a whole lot of extra information about what's actually happening voxel by voxel in the tissue, there's also suggestions that perhaps even in the first 10 minutes of data acquisition, we can actually answer the question and get the same result as we would at a 60-minute static acquisition. So it is very much in the research realm at the moment. I think there's a whole lot of interest. And again, for Theranostics, it's going to be, I think, incredibly important in the future. It's going to allow us to interrogate tissue at the voxel level much more than we currently can. Something else that's really fantastic about the Siemens Quadra system is that it also offers a massive X-ray dose reduction if required through the use of a tin filter that can be applied across the X-ray CT beam. Now, publications indicate that this can reduce the CT dose by more than 90%. And obviously, in certain cohorts of patients, this is incredibly valuable. I've got an image example here of a pregnant patient that came recently to the department, only injected with 40 megabecquerels of activity, and we increased the scan time a bit up to 20 minutes to sort of counterbalance those lower counts that were available. But in this case, using the ultra low dose CT with the tin filter, the overall effective dose for the patient was less than 1 millisievert. And given the absolutely remarkable image quality, I think that's pretty incredible and not something that we would have thought we could do sort of 5-10 years ago. Certainly, again, for the Theranostics patients, I think this could be incredibly valuable if we're looking at doing planning or predictive dosimetry where patients have multiple images acquired over the few days after injection. They don't need to have a high quality CT for all those image data sets. One is enough, and then perhaps we can look at using an ultra low dose CT for the other data sets. And of course, the best thing about this is that it doesn't significantly alter the reconstruction of the PET, either qualitatively or quantitatively. Image quality certainly has already been touched on. The gains in image quality are really superior over to a standard PET CT system. We get fantastic visualization and also quantification of things like those small lesions, which is really important, not just at the diagnostic stage, but of course, measuring response as well. And this is just another example of that. Also, something that Michael mentioned is this ability to do both studies on one day. So some of our patients do require more than one radiopharmaceutical to be injected to work down that theranostics pathway. And of course, the classic example is the NETs patients who have both gallium dotatate studies as well as FDG studies. And so there's a lot of interest in trying to do both of these scans together so that they don't have to come back to the department on different days. Many of our patients don't live locally. It's very onerous for the patients. They have to stay overnight somewhere and so forth. So if we can do these together, perhaps over the space of a few hours, it's really in a lot of interest for our theranostic studies. And this is something we're currently exploring using the approach probably of doing a smaller dose of the more rapidly decaying gallium-68 dotatate to start with, wait for a few hours, and then inject a standard activity of F18 FDG to sort of swamp out that signal. Again, something that's been measured is this idea of late time point imaging, and it's absolutely remarkable the improvement that you see using this scanner. This is an example from the iFirst study. I suspect it might actually be the same example, where patients are only given 40 megabecquerels of I-124, which is, of course, one of our more long-lived PET tracers, so really has a big role to play in theranostics. And we image them at 24 hours and 96 hours post-injection. And the image quality with such a low amount of activity and even out to a few days is absolutely remarkable. And as I mentioned earlier, this idea of doing late time point imaging is essential if we want to do any predictive planning dosimetry where we need late time point imaging to really model those time activity curves. So this is the perfect scanner for that. And last of all, I just wanted to highlight some of Jackie's research, who's here today, a PhD candidate from the University of Sydney. He's done some great work trying to look at not just the benefits to patients, but actually the benefits to staff working in a theranostic centre once we move across to a long axial field of view scanner. And in this case, he found a significant reduction in staff dose that is received when running the PET system. And so not only is this sort of total body PET system beneficial for our patients, it's also, of course, beneficial for our staff. I did also want to touch on some new equipment which should be landing in the next 6 to 8 weeks within the department, which is the Veritan Spec CT system. I mentioned earlier that a lot of post-treatment imaging, particularly for obviously confirmation, but also quantification and dosimetry, relies very heavily on Spec CT. And this is really exciting because this is the first time we've seen this revolutionary design to Spec CT systems since the introduction in the clinic back in sort of 2001. You can see that it looks more like a PET CT system. Gone are the sort of gamma heads that rotate around the patient. Instead, we've got these slim digital detectors that can move very close to the patient body and retract, and they also swivel in place, providing hundreds of views and a lot more data than was previously available with the old system designs. So this system is quantitatively accurate for a range of radionuclides, things that we would typically use for diagnostic studies, technetium, gallium, but also really importantly, a lot of our theranostics radionuclides. So the TCM177, copper-67, actinium, and so forth. It certainly has an improvement in quantitative accuracy. So we're talking within 5% of true value. So now we're looking at values that are really on par with what we expect from PET-CT systems. There is a improvement as well in the spatial resolution, particularly for medium energy general purpose collimators. So this is really what we're dealing with for post-therapeutic imaging. So that's fantastic to see, very valuable when we're looking at things like total tumour burden post-treatment. There is also big gains in sensitivity from this system. Again, for Theranostics, this is really ideal because, like I said, using those late time point images, typically counts are very poor. They require very long imaging times. So with this system, we should be able to get much better image quality at those late time points. Also that results through to improved quantification in SPECT as well, better modelling of the corrections that get used. And finally, that goes hand in hand with that, I suppose, is the rapid scan times. So typically a standard SPECT-CT system for a whole body SPECT-CT of a bone patient might take about 40 minutes. With this system, we're expecting that to take about 15 minutes. So this is coming soon, and we're really excited to have it on campus and to see how it complements the already great imaging that we have available with the total body PET for the Theranostics that we run here. So just briefly mentioning some of the Theranostics pairs that are available here at Royal North Shore Hospital. I won't go through all of these, but I just wanted to quickly highlight too that I think in particular, we've played a big role in terms of the imaging that's involved in really promoting these Theranostic services. So first of all, looking at our NETs. So we've treated over 400 patients since NETs came on, the dotatate and lutate came on board in 2013. We are here at North Shore a European NET Centre of Excellence, and that's really credit to a large number of people here on campus who put in a lot of time and a lot of effort to making that happen. We typically treat 4 to 5 patients per week with lutate, and they follow the 8-week cycles. And all patients receive this baseline mid-cycle and follow-up, usually FDG and combination. So again, that idea of same-day imaging is of great interest to this cohort. And until very recently, we've also done post-treatment dosimetry based on quantitative SPECT-CT for renal dose estimates on all of our patients as well. So just highlighting briefly a few of the contributions from North Shore to this area of Theranostics. David Chan in particular has worked very hard towards the PETNet grading score, which allows the consideration of both dotatate avidity and FDG avidity on a lesion by lesion basis to determine whether patients are better off going down the Theranostics lutate path versus perhaps chemotherapy. There's been a lot of work to really establish this as an image-guided therapy, and also to look directly at the effects of radiation dose on renal function and blood counts. And also we've done quite a lot of work on post-treatment imaging for dosimetry, in particular trying to come up with methods for more rapid-based dosimetry that can be easily incorporated into the clinical workflow. And this is an example of using single time point dosimetry post-cycle 1 to produce results that really are on par with multi-time point imaging. The second one I wanted to highlight is CERT, which is really a Theranostics pairing in terms of the technetium MAA for planning and Y90 Cercius for therapy. We treat about 30 patients per year here, which is both a mix of primary and metastatic liver malignancy patients. We've had a very long-standing collaboration with Certex Medical, both in terms of research and also in terms of education. Some of the contributions, I think this might be a bit frozen. Some of the contributions that we've made to CERT overall from North Shore, particularly with our imaging here, are, for example, the development of the guidelines for yttrium-90 PET imaging. This was a very large multi-centre study that we ran with about 50 sites around the world, funded by Certex, trying to establish how we can best image Y90 post-therapy on a PET scanner, and also in particular how we can optimise the quantification. I just wanted to highlight the images, which you unfortunately cannot see right now, but just demonstrating the massive difference in image quality between Y90 on a standard PET-CT system and a total body PET-CT system. And this was something that Michael did specifically mention, this idea that Y90 is not a PET tracer. It is not designed for imaging, but 30 out of every million decays does result in a positron emission. So there is a very tiny signal. And because we have such large amounts of activity all concentrated in one region, we can in fact image with the PET system. And certainly having those gains in sensitivity on the long axial field of view make a massive difference to this, not just for qualitative purposes, but it really should also improve the quantification where we reduce the noise component. We've done quite a lot of work promoting the use of post-treatment dosimetry and how that can work towards things like tumour control probabilities and predicting response. I also wanted to highlight some of the radiobiology research, which has been particularly led by Yasser Ghalami here on site at the Kolling. He's done a lot of cell survival work comparing directly in vitro studies of Y90 versus external beam radiotherapy and what effect that has, so that we can try and understand how the grey that we measure from a Y90 PET dose map compares to the typical grey that we think of, and also historically in the context of our understanding of dose toxicity thresholds and response measures and things like that. This is very much an active area of research across radionuclide therapy as a whole, and I think Yttrium-90 offers us one of the best possible scenarios for looking at this. I think we might be the only site in the world that routinely does membrophenin spec CT on all Y90 cert patients to build into that treatment planning process. So it gives us a regional map of liver function, which is incredibly important to consider when we look at the predicted dose distribution that will be received from treatment when we're at the MAA planning stage for our Y90 certs. And that certainly has made a big difference overall, particularly in confidence when dosing our selective treatments. And lastly, we've also, I think, really contributed to this idea of considering CERT as a true theranostic through from the planning stage with MAA predictive dosimetry, post-treatment dosimetry with Y90, follow-up imaging to try and understand that radiobiology and look at those tumour control probabilities, the toxicity estimates, and feed that back into the other CERT experience that we have here on site. So I was just going to finish up by quickly mentioning some of the other Theranostics clinical trials that are taking place on site or will be soon. I have already touched on, this is the thyroid carcinoma patients looking at using TKIs to re-establish iodine avidity. And the nice thing about the iFirst study is that it is actually using predictive PET-based dosimetry to determine whether patients do or do not go on to I-131 treatment. So it's really exciting to see it being used in this way. The Alpha-9 study, which is, I think, gastrin-releasing peptide receptor, I believe it's still in the phase 1 biodistribution and will be moving through to treatment with actinium for phase 2. There is the prostate global study looking at the lutetium-labeled antibody from Telix for prostate cancer. Alpha-Tate, which I don't think is the official name, but it's what we call it. This is again looking at actinium-225, this time in NETs. And then there's also the IPAX-2 study for GBM looking at FET-PET followed by treatment with I-131. So there's a lot happening in this space, and I think it's really exciting to see all of these advances in imaging hardware and software really contributing to the path of Theranostics. So thank you very much.
Thanks, Kathy. Yeah, sure. So thank you very much for two excellent talks, Michael and Kathy. And apologies for a few technical issues in the room. I believe they weren't experiencing those online, but we had challenges here. But thank you especially for Michael and Kathy to sort of navigate those issues. Time for Q&A. So are there any questions online, Georgios? Not yet? Okay. Well, please go ahead.
So I'm wondering, in terms of analysing the results, the outcomes, do you integrate blood tests? I mean, measure the PSMA, and how does that pan out comparing the imaging versus measuring PSMA in the blood after therapy?
Yeah, so there's two terms and they shouldn't be confused. One is PSA, which is prostate-specific antigen, which is the common blood test that's used for men with prostate cancer. And then there's PSMA, which is a receptor expressed on the cell surface that we're targeting with the theranostic approach. So PSMA can't really be measured in the blood. We did actually try to do it in our very first phase 2 trial. There was some very old assays for measuring serum PSMA, but it's just a scattergram. It doesn't seem to be a useful blood test. So there is no way of sort of measuring it apart from doing the PET scan, but there are other sort of blood biomarkers. But when we're looking at expression of the target, I think you can't beat the PET scan. It's a very, very good biomarker because the expression of PSMA varies tenfold. We see some patients with SUVs of 10 and others with SUVs over 100. And without the
Are
scan,
there any other theranostics where a companion blood test might be useful?
it's a good question. If I think of radioactive iodine, I don't think so. We measure it on a scan. I think neuroendocrine tumours, there is no surrogate for an SUV on a dotatate PET scan. So there always are some conventional biomarkers that are measuring very different things that are always going to be useful. But when I think about it, I think our PET biomarkers
So that makes the
very powerful.
and the timing of assessing the therapy post theranostic use is quite important to figure out. Is that true?
Yes, and just doing imaging in general, because this is not everyone believes that you need a scan before you treat. There are people in the world that say, well, PSMA therapy is very effective. Let's just not bother with doing a PSMA PET scan first. Let's just treat everyone. And in fact, theranostics is not necessarily that different than the rest of oncology. The rest of oncology, oncologists do treat blindly. They don't try to measure the target on a PET scan. They could. So for a radiolabeled rituximab in lymphoma, you could do a CD20 scan and try to measure it. It's not something that hematologists try to do. And I think one of the fundamental limitations in oncology to date has been not measuring the target properly and not measuring tumour heterogeneity, because on a PET scan, not every metastasis has the same degree. So I think this is a really powerful tool.
Any other questions from the room or online?
So can I just add to that? And you've heard about this in the seminar, but it's more than just one biomarker on the PET. If you add the FDG in, you're starting to get a much more complete whole body biopsy and looking at the evolution of different clones of the disease. So I think we're at a level in Australia of understanding that to some extent. The rest of the world, not so much catching up, but it really is very powerful in guiding therapy and who's going to benefit most from the therapy.
Yeah, I understand that PET scanning for the marker is superior to MRI, for example, because MRI can be misleading. The tumour size might not change after therapy as rapidly as the number of cells that have your target. Is that a reasonable sort of statement as well? I'm trying to test my thoughts.
I think there's often big differences between anatomy, what you see on a CT and an MR, and what we see on a functional scan with a PET scan. So the size tells you nothing about the PSMA expression. In fact, you can have a small tumour that's very PSMA avid and a large tumour that's not. So on anatomic imaging, we're really blind to the cell surface expression, whether it's iodine, dotatate, PSMA. I don't think we can predict it on a anatomic imaging modality.
Is it also fair to say that the response to therapy is seen much earlier from the PSMA expression than from any anatomical markers? I mean, you wouldn't use anatomical imaging to monitor progression, response to therapy, right?
Unfortunately, the editors of many medical journals do.
Yeah.
That's been the standard up to now.
Yeah. So I had another question, Michael. In your talk, one of the things you touched on, which I thought was really interesting, was the idea of a non-static biomarker. Use SUV is the typical outcome measure we use, and you were hinting at sort of kinetic parameters that might have more prognostic value or treatment prediction value. But of course, that comes at the cost of a more complex imaging protocol, potentially having the patient on the bed for longer. But so what's your vision for that? Do you think the value in these alternate biomarkers justifies a patient spending longer on the scanner, or are you thinking more that we need to really work on new protocols that can still extract those biomarkers somehow, but with much shorter imaging protocols?
Yeah, it's a great question. And I think I don't know the answer, which is why it's research. And it's probably something we can maybe combine forces to try to answer, because we need to scan a good number of patients, get the data, and then follow them up to look at an outcome. So to do it properly is not a trivial undertaking. And how long dynamic scan do we need? Don't know. Can we do it with a 15-minute scan? With 15-minute scan at 60 minutes, I can tell whether the isotope is still accumulating or whether it's decreasing, something I can't tell with an SUV. So I'm hopeful that even with a 15-minute dynamic scan, that extra dimension beyond just the number, but the trajectory of increase or decrease will be enough, and that will be a powerful prognostic factor. So I think a 15-minute scan's feasible. 10-minute scan, maybe you can do it in 10 minutes. I don't know. Value your thoughts on this. I think an hour scan, pushing it, like that would be a research indication. It's never going to be translated to the clinic because we just don't have capacity to scan patients for 1 hour, nor do patients want to lie on the scanner for 1 hour. And so I think we need to try to, reduce this imaging time. But it may be that a short dynamic scan tells us a lot more than what we would like to think, because you may have 100 metastases. My idea is that we automatically segment out each metastasis and then just look at the dynamic gradient, essentially, of increase and decrease. We'll get an idea of tumour heterogeneity. If the gradient's the same for all 100 tumours, then we know this is a fairly homogeneous tumour. If it's increasing in half and decreasing in half, we've now got a picture of a patient with multiple clones of tumours. This could be a really powerful biomarker.
Yeah, I agree. I think actually this is where total body PET, there is an opportunity to explore a lot of sort of stuff that you can test some of these questions in a way with total body PET that you couldn't with a conventional PET scanner. And there are people already showing that even a 10-minute sort of dynamic scan on a total body PET may be enough to extract those parameters. It's exciting stuff. Any other questions online, Georgios, or from the room? No? Okay. I'm being given the wrap up. But I think it's been a great discussion and a great webinar. So thanks again to both our speakers for a really excellent session. And thank you everybody online for joining us. We'll end the webinar now.